Hey guys, I hope you're enjoying your first week of PGHE. Welcome to the second session, which is going to be focusing on global burden of disease. This session is going to be led by Dr. Emily Wroe. Dr. Emily Wroe has been teaching in the PGHE course for the past few years. She's a true implementation expert. She has extensive experience in Rwanda, Malawi, and other countries around the world. She has been Chief Medical Officer for Partners in Health in Malawi for some time, and now she's leading the Massachusetts COVID-19 contact tracing collaborative that was started by PIH. So she's now the director of implementation and design for that collaborative. So I think the knowledge and wealth of experience that she brings to this course is very central, and I hope you enjoy her lecture. I will now welcome Dr. Emily Wroe to take over. Thank you.
Hi, UGHE. My name is Emily Wroe. I'm excited to be giving you this teaching on the global burden of disease, and hope everyone is doing okay and staying safe during such a tough year and tough times in the world. And I wish I could be there in person with you, but hopefully we'll get to meet you in person one day soon. I've been doing this lecture the last couple years. I'm a physician working for Partners in Health and spent the last several years working in Malawi on different programs, including NCDs. So I'll show you a little bit of that work in this lecture today. And I'm now back in the United States working on some contact tracing programs for the state of Massachusetts for the COVID-19 pandemic. So with that, we'll get into talking about the global burden of disease. So the objectives of this talk are to really summarize the global burden of disease. What do we mean by that and why does it matter? And then to make sure that you're familiar with some of the common measures of disease burden, such as incidence and prevalence and disability adjusted life years. And then I'll talk to you about, we'll use the global burden of disease study as a way to illustrate some of that and look at the practical applications of it, and then some brief introduction to some other tools just to give you a sense of what's out there as you embark on your career in global health equity. So when we look at the total disease burden in the world, we'll talk more about what DALYs are, disability adjusted life years, but this is like a very zoomed out image of blue for non-communicable diseases, the pink for communicable or infectious diseases, as well as maternal, neonatal, and nutritional diseases, and then the gray in injuries. And you can see the relative contribution of those to the global population over time, and how NCDs are increasing proportionally to that, and that we've made some progress on the communicable, maternal, neonatal, and nutritional conditions. But one thing that's just really important is we have to look at things over time among specific populations to really understand what programs we need to put in place to respond. So if we were going to look, for example, at the top causes of death and disability in the world in 2016, and this is not a surprise to anyone listening to this, but it's a very different makeup of the burden of disease for people living in low income settings as opposed to high income settings. So you can see a lot more blue over here, and which doesn't mean that people here aren't at risk for the blue, but it does mean that there still are a lot of burden from infections, malaria, diarrheal diseases, tuberculosis, HIV, and a lot of malnutrition contributing to the top causes of death and disability. So this is just to say it's important to think about what population and what setting are we thinking about. And there's lots of different ways to look at data that can help inform our approaches. These are some maps that you may have seen. It's from worldmapper.org, but different ways to visualize this sort of thing. So this is just land area. So this is like what the map of the world looks like if we just look at land area. And what this group does is changes it to have different lenses. So if we look at maternal mortality, you can see the land area go to places where a lot more women are dying in childbirth or immediately after childbirth here. And this is also not going to be a surprise to people that this massive impact in Southern Asia and in Sub-Saharan Africa for maternal mortality. And then if we look at that and then we look at health spending, it's almost the opposite, right? So here's where we're seeing a lot of maternal mortality, and then the health spending is much less in those areas. So already we're starting to see kind of a different way to visualize inequity. So what is the burden of disease? So the definition of the burden of disease is the impact of a health problem on a population as measured by morbidity, which is disease, disability, kind of the sickness, mortality, which is death, financial costs, and other indicators. So there's lots of ways to talk about how we're measuring the burden of disease, with our ideal goal to be everybody living until old age free from disease and disability. So the burden of disease tries to get at how much of this healthy life are we losing because people die earlier or because they're disabled or ill while they're still alive. So it's the gap between actual health status and ideal health status. So this is a way to visualize it, with gray being healthy life from birth, going through, maybe this was an infection, a little later, a little bit of more of a prolonged infection, and then eventually this person gets a chronic disease or disability and is still living out their life, but with a reduced quality of life or some sort of disability that's impacting their health. And then they might have an earlier death than we otherwise would have expected. And this is where the mortality measurement comes in. So why is it important to talk about the burden of disease? We need to be able to assess epidemiological patterns. So how are things changing over time and in different disease areas and in different geographic areas? And then once we know that, we need to assess our health system performance. How are our efforts at reducing morbidity? Is it working? What else do we need to do? We need to prioritize how we invest in health systems. Are we reaching our most vulnerable patients? Are we matching our interventions with what the population really needs? So it's important to be looking at this data in a very practical way in that sense. And then we use it to prioritize. So where do we need more data? Where do we need to invest more? Where do we need to develop health systems more? Where are our gaps? And then it helps us monitor our progress toward our targets. So here are some terms that you should all be familiar with after this module. So life expectancy, mortality, morbidity, incidence, prevalence, and DALYs. So life expectancy is, you've all heard about this. It's the average number of years from birth that a person can be expected to live. So generally with life expectancy statistics, it's kind of defined by the year that you were born in. So there's kind of interesting things that happen in life expectancy data when there's like large disasters and other things. You can see a blip in them, and I think the COVID-19 pandemic might show us that in the months and years to come as well. But life expectancy is basically how long can we expect to live. Mortality is the one that you should really be familiar with is the maternal mortality rate. We also have infant and neonatal mortality rates that we commonly look at. These are a rate, so it's a ratio between two numbers. So the number of deaths divided by the number of events. So for maternal mortality, the rate is defined as the number of maternal deaths per 100,000 live births. So this is women during pregnancy, childbirth, and then the immediate postpartum period. And so for every 100,000 live births, how many women are we losing there? Neonatal and child mortality are measured per 1,000 live births. And then maternal mortality, as everybody probably knows, is a way that we measure kind of the overall health system oftentimes because of the inputs that need to go into keeping women safe during and just after childbirth. And this is just a graph from the World Bank Open Data. Tried to put some different data sources you might like to look at in this presentation. And this is India, declining over time. So a lot of progress, but still a long ways to go in India. So incidence, so we're going to talk about incidence and prevalence. Incidence is the number of new cases of a medical condition divided by the population at risk over a specific period of time. So incidence is also a rate. So here's an example for tuberculosis from Rwanda. So in 2015, we had 56 per 100,000 of the estimated TB incidents. Now, we have to know what this means for incidence, right? And the denominator for incidence is the total population at risk, which in TB is everybody, right? So it's per 100,000 people living in Rwanda, 56 new cases of tuberculosis in 2015. So incidence is measuring kind of new cases as they crop up in a society. That's different than prevalence, which I'm going to show you on the next slide. So again, just to repeat, 56 new TB cases for every 100,000 people during 2015. But so this number, this 56, doesn't include anyone who might have been diagnosed at the end of 2014 and is still on tuberculosis treatment. It's just the people who were newly diagnosed in 2015. Prevalence, on the other hand, gives you the total number of active cases of a particular medical condition at a specific point in time in the population at risk for the disease. So let's look that we're going to look at hypertension here, using the STEP survey, which is a non-communicable disease survey. So incidence only included new cases. Prevalence includes all cases, new and existing. And so for hypertension, now we're taking a different population at risk. Age 15 to 64 years is what the STEP survey defines. So we're taking that as a different denominator, right? Whereas TB, we use the whole population. For this, we're using this age group, 15 to 64 years, and saying 15.9% of the people in Rwanda between the age of 15 and 64 had elevated blood pressure. And this was in their 2012-2013 survey. So that includes people who were newly diagnosed during that survey and people who already had hypertension and knew about it before the survey. So though that's the difference between incidence and prevalence. The other important thing for everybody to know is disability adjusted life years, DALYs. So this is a very commonly used measure of overall disease burden in the population. And that's because it combines morbidity, illness, and mortality, death, into a single metric. So this is the number of years somebody loses either because they're in poor health, or they have a disability, or they die early. So one disability adjusted life year is 1 year of healthy life lost. So let's look at this. So here's the healthy life, right? You basically have to add up all the red to get into your DALYs. So if you wanted the DALYs from whatever the disease or disability this person developed here, it would be all of these years of disability from that condition, and then these years of early death from that condition. And so this person maybe got like dementia or something. That would be the DALYs from dementia because they were disabled for years and then they died early. So here's an example. I'll show you a few examples from our Malawi NCD work in this talk. But we were looking at more than a third of the burden of disease in Malawi is due to non-communicable diseases and injuries, which is a simple pie graph, but is a little bit striking because whenever a lot of even funders, right, think about what do we need to do, we definitely need to address the things in orange: maternal mortality, HIV, tuberculosis, malaria. But we also have a third of our burden of disease coming from the non-communicable disease and injury side. The other thing just to know about DALYs is that there is a disability weight that is included in the calculation. And it basically says that you can be disabled from like low back pain and you can be disabled from dementia. And those levels of disability, like how serious that is, are not the same. So we might say that dementia is a bit worse. This is taken from real lived experience from people, and they've put disability weights to specific medical conditions. So basically 0 is a condition that confers no disability, and 1 is a condition that causes death. So it's a number between 0 and 1, and the higher disability weight means more disability. But that's just to understand that disability is different between different illnesses and injuries. So if we have a person with type 1 diabetes, though, we would say, okay, we have one person diagnosed at age 11 and died at 62 with a healthy life expectancy of 82. So years of life lost here are 20, right? This person died 20 years early. And then this person had years of disability of 62 minus 11, so 51. So we might say, in a simplistic way, this person had 51 years of disability plus 21 years of early death. So they would have, 20 years of early death. So they would be 51 plus 20 is 71 DALYs. That doesn't take into account the disability weight, but you get the idea that it's kind of trying to incorporate the morbidity, the illness or disability, and the mortality. So the Global Burden of Disease Study is a comprehensive global and regional research program to over time assess disease burden from major diseases, injuries, and risk factors. It started in 1990. The 2017 data is actually out now. There's more than 3,000 researchers in more than 130 countries, and it's headed up by an institute, IHME in Seattle, and the WHO. And they're capturing data on death and disability from more than 300 diseases in 195 countries. So it's a huge amount of data. You can go on the GBD website and look up what's input into my country. So for example, in Rwanda last year, there were 148 sources used in the estimates, which includes large surveys that you've heard of, in addition to peer-reviewed literature and many, many other things. And you can actually see how were these estimates calculated? What was the data input? And the link is here in the slides. So overall, the Global Burden of Disease study can show us trends where you can see so red is always the infections and the maternal neonatal child health and malnutrition, and blue is NCDs, and green is injuries. So you can see things generally decreasing with a much more precipitous decline over time from the communicable diseases, and a lot of this represents all the progress in HIV, TB, in malaria. But you can see this. What this is also showing us is total DALYs from 1990 to 2016 by quintile of wealth. So they're using a sociodemographic index here to show us kind of how it's changed. And you can just see, like, once you break down a population by different wealth quintiles, much different things are happening in the most poor quintile, which is this one on the left, versus the wealthiest, which is the one on the right. So important ways to slice data to really get at what we're looking at. And then this is another just large picture image from the Global Burden of Disease study over time. So you can see 1990, the leading causes of DALYs, to 2006 to 2016, and how there's shuffling, right, worldwide in kind of what the number one things are. You could see lower respiratory infections falling, ischemic heart disease rising, and how kind of things have changed over time that are affecting the global population. The Global Burden of Disease resources, just some practical things for you to look at. There's country profiles, and then there's visualizations. So in country profiles, this is a country with 6.6 million population. It tells us the GDP per capita, the fertility rate, and the educational attainment. And then you can look over time at life expectancy. This country is for Sierra Leone. So you can see here, I mentioned, remember, the Ebola epidemic can cause big blips. The earthquake in Haiti did this to life expectancy, and we probably will see something similar for COVID in the coming years. So this is a Sierra Leone example. So are the next few slides, just to give you a sense of what you can find on this website. You can look at premature death. So what are the top causes of premature death over time? Malaria has stayed number one in Sierra Leone from 2005 to 2016. And a lot of things have actually stayed very similar for premature death in Sierra Leone. You can also see what are the risk factors for DALYs, for death and disability. So number one from over this 11-year period has remained malnutrition. for Sierra Leone, sanitation and hygiene, air pollution. So these are not specific diseases, right? These are risk factors for diseases and for death and disability, and how these different risk factors are playing out in the population. This is for Sierra Leone as a whole. If you were able to look at the different levels of wealth in Sierra Leone, you'd probably also start to see different risk factors for people living in poverty versus people living in better circumstances. And I'll show you a little bit of that in a minute. And then it also has some sources on health financing that you can look at in your country profile as well. The other thing I want you to know how to use for global burden of disease is to look at this, to look at data for burden of disease over time, look at trends, look at genders, look at countries, and to investigate risk factors. And so you really can go from global into more specific views. So this is called GBD compare. So this is one of the types of plots they use, which the whole square on the slide is 100% of the disability adjusted life years in 1990. So here's lower respiratory infections and diarrhea, measles, HIV was this much. And then you can see all the NCDs and the injuries. And this is the global. So this is for the whole entire world. And now watch the slide as I flip to the next one, what happens in 2016. So you can see we've won some battles, right? In the red, and then the blue is proportionally making up more. So this is a different way, more specifically to visualize some of the stuff I showed you at the beginning of this talk. And then you can even look at little ones. So even though red got smaller, look at the size of HIV there, it's bigger in the world, right? So now if we look at a specific country, so now we're back in 1990. This is the Democratic Republic of Congo. And you can see in 1990 just a huge burden proportionally of red, people dying and having disability from neonatal causes, diarrhea, malaria, measles, lower respiratory infections, TB. And now I'm going to fast forward to 2016. So watch how this changes. So again, still quite large red box, right? But you start to see a bit more proportional contribution from our blue NCDs and then our green injuries. So some practical examples of the use of this is we've used this on our team called NCD Synergies at Partners in Health. There's I think almost 20 national NCDI poverty commissions right now, and this is a report from Malawi in 2018. They're having a regional launch for this actually later this year at the end of 2020. So all the countries that did this analysis can come together. The global analysis was just published in early September 2020. The Lancet in the Lancet. So it's the Lancet Commission launch for the burden of NCDs and injuries in the poorest billion in the world. And what I'm going to show you is a national level analysis for Malawi. So I showed you this before. This is us looking at DALYs, so death and disability from non-NCDs and injuries, contributing to quite a lot of death and disability in Malawi. And then we did this and we used global burden of disease just to show a few things. So one thing we showed was actually NCDs aren't just in old people, right? It's not just old people who smoke and drink and have high blood pressure. A lot of the NCDs and injuries in Malawi are actually happening before the age of 40. So in the young, and look at all this green is injuries. And it's a different makeup of the NCDs and injuries in the older people, but a lot of things happening in the young. So trying to dispel the notion that NCDs are a problem in the elderly, which is not shown to be true in Malawi. And then we also used the global burden of disease to look at specific conditions. And so here we're looking at a big list of NCDs, things that people don't always think about: acute lymphoid leukemia, poisonings, epilepsy, burns, appendicitis, rheumatic heart disease, cervical cancer, and showing that in Malawi, we're losing, for everyone who dies in Malawi, we're losing a lot more years of life than we are in high income countries. So let's look at epilepsy. So someone in Malawi who dies of epilepsy is losing almost 60 years of life versus, in a high income country, somebody's only losing 30. So you're just dying a lot younger in Malawi from an NCD than elsewhere. Again, this is kind of intuitive, right? We know that there's inequity in health systems and in the world, but this is a data-driven way to say, hey, look, this is a list of really important things that we need to pay attention to and work on a health system that can be responsive to try to help people live longer, have less disability, and reduce inequity. And we also looked at the risk factors for the global burden of disease and said, well, okay, everybody might say that the NCD burden is actually being overweight, smoking cigarettes, eating salt, drinking alcohol. But when you really use this data, what comes to be true is that this red part is that this is DALYs from NCDs that we can't attribute to these sort of classic metabolic and behavioral risks. This is the hardest one of a lot of people to understand because the dialogue about NCDs is that they're caused by lifestyle risk factors like being overweight or eating a lot of salt. But the data actually doesn't support that at all. And a lot of the risks that aren't accounted for are things like hepatitis B causing liver cancer, or HPV causing cervical cancer, or malaria or birth asphyxia contributing to the burden of epilepsy. So we were using the global burden of disease data in a way as advocacy to say, hey, we need to shine a light on what is really truly happening in populations, what's causing disease, and how can we design responses and direct funding to try to really address what it needs to be. So would encourage you to go to GBD Compare and find something sort of interesting or surprising about your country. And I've put the URL there. We have to know that there's limitations of these estimates. So if the primary data they're derived from isn't good, that means the estimates won't be good. So there's definitely limitations in that. And then a lot of this also is simplifying a fairly complex reality into single numbers. And so if some of the assumptions are inappropriate or the contextual factors aren't there, we have to combine this kind of data into a conversation where the reality on the ground and the context is also incorporated. So it's just about sort of what are the limitations, how do we think about that, and how do we present this kind of thing for decision making where it's not taken in complete isolation from the lived experience and important other contexts. And in addition, the data is getting better at assessing equity, but there's still definitely limitations there. So a couple things about equity. If we think about wealth status in a population and differences within a country, so like where I was talking about Malawi, how do we measure across wealth status across populations? So just wanted to point you toward a few resources. There's demographic and health surveys in pretty much all the countries where you all are from. And a lot of them will have an equity tool, which is derived from the DHS, which is a shorter questionnaire that is limited to 10 or 12 questions and can put respondents into wealth quintiles. So often a good thing to incorporate into different surveys and research and things so that at least it's a bit of a blunt instrument, but it starts to get at, are people living in more extreme poverty, in quintile 1, much more affected than quintile 5? And then the other one that is kind of commonly used is this multidimensional poverty index that looks at 10 indicators of poverty across education, health, and living standards, and puts people into, gives them a value in the multidimensional poverty index. And this has been used in some large analyses, including the Lancet Commission on NCDs that I mentioned. So here's a practical example of something we did with wealth quintiles. This is using the Malawi equity tool. And we took the STEP survey and we said, okay, diabetes is, whatever prevalence across the population, but how does that look like across the poorest to the wealthiest? And same with epilepsy. And what falls out immediately is something that's probably fairly intuitive is, number one, you can see way more people with diabetes in the wealthier quintile. Now, that might be attributable partly to lifestyle, but I would argue this is probably attributable as well to access to care and people that actually have had a finger stick, right, and know they have diabetes. So that's kind of one way to think about that. And then in the epilepsy side, we can see a lot more people in the poorest quintile than the wealthiest having epilepsy, which isn't surprising if you consider the biggest risks for that are cerebral malaria as a child, cerebral meningitis as a child, or birth asphyxia, so danger around childbirth. So that's kind of a practical way that we used this to sort of advocate around disparities in the NCD world. So here's a list of terms that we talked about. We didn't have time to talk about the SDI today, but you can take a look at that. But it's another sort of index that tries to get at social determinants of health, looking at health and education and wealth together to try to make sure that as we look at data, it's really important to think about who's our population of interest, where are they living, what are their living conditions, what are their social determinants of health. And I know you're going to have a lot of different practical exercises with this module, so have put a lot of URLs at the end of this that might be interesting for you, and excited to meet you all one day soon. And I hope this helps give you at least an introduction to the global burden of disease. And so thanks so much again. I'm Emily Wroe, happy to chat with anyone. And take care, everyone, and good luck in your course. Thank you.